what's the name that you would give to this condition that men have? Would you call it prostatitis or chronic pelvic pain or a dysfunction?
Right. So that's a really good question, Simon, and many thanks for asking me to do the interview. I think the naming of the condition or syndrome really adds to a lot of confusion and also a lot of additional distress for the men who have pelvic pain. I think the kind of commonly used term is chronic pelvic pain syndrome. That's moving a little bit to maybe persistent pelvic pain syndrome. I think, though, that the terms that are used by a lot of the medics, particularly the urologists, is type 3 prostatitis. So I think historically all pelvic pain was looked at as being prostate in origin. But we now know that that's not the case, that probably about 95% of men have chronic pelvic pain that's not prostate related, that's not due to either an acute or chronic bacterial infection of the prostate, but it still comes under that umbrella. So when you look into the classification, it'll be termed under that umbrella term prostatitis or type 3 prostatitis, but it is chronic pelvic pain syndrome. So the urologists might, they will mean that that person has got chronic pelvic pain, but they may still call it prostatitis. So the problem that you see then is these men, some of them feel that, well, I don't think I've got a prostate problem because my bloods are fine. I haven't had signs of an acute infection. I've had an ultrasound, it's been fine. I've had repeated tests. My prostate is fine, but why are they still telling me it's prostatitis? Now I think that's improving because I think more people are tending to use the term chronic pelvic pain syndrome. However, within chronic pelvic pain, you've also got a lot of men who've got bladder pain syndrome. So they're the men whose symptoms are heavily related to kind of bladder function. And then you've also, I think, although we talk about chronic pelvic pain, these patients or these men present very differently. So you could, and kind of in preparation for this, I was thinking of some of the men I saw last week, in that I saw one man and his main problem was quite nasty ejaculatory pain. It's quite nasty pain related to sexual activity. So he was fine on sitting, he was fine driving. So his main symptom was on masturbation or sexual activity with his partner, he was getting huge flare up in symptoms. I saw another man and his main symptom was bowel pain. So he would get really bad scrotal penile pain post bowel movements, constipation, large stools, difficult voiding, flare up on bowel movements. And then also several patients who have that more kind of classic presentation of pain in the perineum, scrotal, maybe lower abdominal pain, who really find sitting problematic. So they can't sit, they can't drive, or those things are painful. Their function is limited. They've given up a lot of their activities. And then also you get some of the patients whose symptoms are very much maybe activity related. So some of the young guys who've got maybe pelvic pain because they're doing lots of weightlifting, lots of squatting. So under that chronic pelvic pain kind of term, these men present really differently. So you've got men who've got a lot of pain as the main symptom. You've got men whose condition is very urinary focused, bowel focused, ejaculatory. And that's why it's important that these patients have a very individualized approach, because although they've all got pelvic pain, they present like completely different subgroups. And I think that's where things are starting to go now, is some of the big research teams, which is relatively new, are looking at, well, how can we subgroup these patients? Because if you subgroup patients into patients who have similar type symptoms, it's likely or hopefully that it will be easier to work out what they respond to, rather than trying to treat them all with a very similar approach, because that doesn't work.
Okay. So with all these different symptoms presenting, what's your approach as a physiotherapist to try and help someone manage or even, improve someone's symptoms?
So I think probably the first thing I do, and I think I'm relatively fortunate in that in my clinic in Birmingham, I work with a really brilliant men's health physio, Lisa. So there are two of us. We used to have a third one, but he's kind of left to work somewhere else.
Right.
And we also have like a lot of experience in treating female pelvic pain. So that's kind of what we probably did first. I think what we do is we spend a lot of time doing a lot of kind of detailed questioning of these men, i.e., what symptoms they're getting, what's going on in terms of pain, sexual function, bowel, bladder. We work out what's going on, trying to work out, what's led to this, what intervention they've had, what's going on in terms of general health, what's going on in terms of their stress, anxiety, mood, behavior, activity. And I think also trying to work out what they understand as to what's going on. Because there generally does tend to be most of these men, by the time they see us, have been through several kind of maybe urologists, colorectal surgeons, spinal surgeon, some may have been through a neurologist, some maybe sexual health consultants. So it's trying to also work out what they understand. In terms of some of the key things we do to assess these men, we look at them from a musculoskeletal perspective. That's really looking at, well, what's their spinal, hip, pelvic movement like? We look at what's happening in terms of their abdominal function. Some of those big hip muscles, are some of those big hip muscles tight? Are they shortened? Are they weak? So we do a lot of that's kind of stuff you do with a back pain patient. So we do a lot of that. Okay. Then we look at the pelvic floor externally. So we do that. We put like an ultrasound probe on their lower tummy, kind of almost between the belly button and pubic bone. That allows you to visualize the bladder. It allows you to visualize what's happening in that pelvic floor. So you and I are, if everything's going well, we should be able to contract and relax that pelvic floor. We should be able to contract it fast. We should be able to contract it slow and hold it. We should be able to get it into a position where it's descending. So you can see that in an ultrasound scanner. It's quick and easy to do. So we look at that pelvic floor function that way. Then we also do a lot of abdominal muscle palpation, because one of the big things there's general agreement now is that these men get marked hypersensitivity. So if a patient comes to see one of my colleagues with back pain, they don't tend to get this hypersensitivity. So that's where you press into those abdominal muscles and it's very locally painful, or they're getting spread of pain, or you press into their tummy and they're getting penile pain or scrotal pain. So they get this hypersensitivity. So we assess for that. And then with some of those men, we assess them internally. And that's really looking probably for two things. That really relates to the pain mechanisms. That's looking, well, is there a thing called allodynia? So allodynia is a phenomenon where something that normally shouldn't be painful is. So for example, if I touch the back of my arm, that should feel like touch. if I move my wrist back, that should feel like a bit of stretch, bit of compression. Whereas if I've had chronic pain in that wrist and arm, if I touch it, that can feel quite painful. If I move it, so when you palpate internally, you're trying to see, is there that kind of abnormal pain response? And also, is there hyperalgesia? Is there an increased pain response when you palpate into that region? So it's kind of not, it's not looking for that kind of trigger point type. It's really looking to see what is the sensitivity of those tissues. Is that changed? Bit like, is it changed in terms of the abdominal function when we palpate the pubic bone? And also it's maybe confirming what we've seen on ultrasound, that this patient, you know, they can't contract and relax that pelvic floor because it's maybe already in a state of contraction. However, I think our treatment has probably, our assessment has changed quite a lot recently, because, you know, we closed in March, like all, well, like the majority of clinics everywhere, especially in the UK. So what we did then from March to probably about July is we did a lot of online male and female pelvic health. So then obviously we didn't do any hands-on assessment with the patient, and that kind of emphasized to me kind of how important that initial kind of conversation is with the patient to work out what's going on and what do they understand.
So what would the steps be? It would be what, stretching, I guess, is that one of the main?
Yeah, so I think in terms of management, so probably the first thing and probably the most important thing is to try and explain to that patient kind of what's going on. So to try and explain why they're getting an increase of pain, maybe with bowel movements. So that's really explaining what normally should happen in terms of bowel movements, maybe what's happening now. It may be that they're getting a bit like the guy last week, lots of ejaculatory pain, trying to explain the mechanic. So it's trying to really explain why those symptoms are occurring. And in terms of the pain, explain a little bit about whether there is some tissue involvement, whether it's muscular, whether there's some spinal referral, whether there's a bit of ischemia so that there's not as much blood to those muscles, and also explaining that high percent. So a lot of the first bit is a lot of education about what's going on.
Right.
Then it's working out, well, what's this person's level of activity? So, you know, those guys in the gym probably need to be pulled back a little bit. Whereas the person who's got quite kind of debilitating pelvic pain, it may be working out, well, how can we introduce some activity into that person's day, but very low level of activity? That may be just getting them doing some walking or something. It may be seeing, can they start to do some gentle exercise? Then we go into, it depends what we find then. You know, the people who are really stiff in that lumbar spine hip, they've got loads of muscle shortening, so they'll start to maybe do some hip lumbar spine either exercises or maybe stretching. The people who've got a lot of hypersensitivity will do, we kind of teach, we try and get the patients doing a lot of this. So we teach them to do a lot of the abdominal soft tissue work. We get them to usually with the, if they're in clinic, it's a bit harder online, obviously. In clinic, we get them to do some work to really get some excursion into that pelvic floor, i.e. get it moving a little bit, get it descending a bit. So we do that with the ultrasound. So we get them doing a lot of belly breathing, a lot of doing that in different positions, like in squatting, in child's pose. And you can kind of, I can say to them, okay, or Lisa can say, okay, if you do it like this, that pelvic floor is not descending. If you do it like this, it is, because you can kind of see that movement. And I think they like that. Guys like visual stuff. The people who've got a lot of maybe internal pelvic floor component, we would gradually progress into doing some internal work with them, teaching them how to do it.
How do you do that? Is it with your
sorry.
finger? Is it with a tool, or is it with just a finger?
So not everyone. No, we don't do that with everyone, but the patients who do that, and that can sometimes be particularly those who've got a lot of anal sphincter component.
Right. Well, it's 210.
So that's quite hypersensitive.
Right.
It's very responsive. It's a bit more contracted. So we would initially do that digitally, finger.
Yeah.
And then progress to doing that with the EZ Magic, which is one of those internal ones, and then get the patient to do some of that.
Right.
But I think it's important to emphasize that that's not with every patient, and that's a small component. Because I think sometimes people feel that that's all it is, and that's a tiny bit, and also it's really trying to get these guys doing stuff that they can do themselves, because we don't see patients that often. Because sometimes patients say, well, you know, like, can I come and see you every week, or can I see Lisa every week, and we would say, well, you know, you've got quite a chronic slow changing condition. You know, if we see you too often, that may be that can be an irritant, can irritate things. And also, if you see people too often, you're not really seeing, well, are things changing, or is this normally this cyclical pattern of good days, bad days? So sometimes it's better to space things out 3-4 weeks, and also trying to get these guys really engaged with doing a lot of this stuff to almost like self-treat, help themselves.
Okay. And what do you think, just on that topic, what do you think of prostatic massage then?
Yeah, so that's probably something that's not done very much in the UK. No. It's the evidence for it is not fantastic. I know it's definitely not something that is done within the physiotherapy community. Right. I think maybe historically it was done in terms of by some of the urologists, but I think, like, you know, we've seen a lot of patients in the clinic, and I have yet to see anyone who's had prostatic massage. Right. That's not in my experience, and obviously people's experience will differ. In the UK, and I'd probably include Ireland in that, it's not something you come across. And then the other thing we do is we are quite involved in kind of just encouraging other people to get involved in pelvic health. And when we either teach in other countries, it's not something that's really flagged up. So people aren't saying, well, I'm getting these patients ringing up for prostatic massage, or I'm seeing patients who've had, so it doesn't seem to be a massive thing.
No. Okay. And so other than obviously the feedback from your patients, what's the other clinical studies to back up the physiotherapist approach?
Yeah, so this is I think this is an exciting area to be in, because you can split pelvic health kind of in two. You've got female pelvic health, male pelvic health. Within female pelvic health, you've got female pelvic pain, and then you've got a lot of urinary dysfunction, incontinence. In female pelvic health, particularly in physiotherapy, the research emphasis has predominantly been in patients with urinary incontinence prolapse, i.e., not a lot of stuff on female pelvic pain. Male pelvic health physiotherapy, people will generally be in agreement that that's probably 15, 20 years behind. There aren't a lot of physios who do male pelvic health anywhere, not just in the UK. And that's also got two areas of which very few people do. So you've got male pelvic pain, which is obviously what you and I are interested in today. And then the other area is male pelvic floor treatment for post-prostate surgery. So these are the older men who've had prostate cancer. And then if you have your prostate removed for prostate cancer, you end up being incontinent of urine and you get complete erectile dysfunction. So in terms of research, the research focus in male pelvic health physiotherapy is not completely focused on post-prostatectomy, but it's heavily focused there.
Right.
But the reason that is because obviously the incidence of prostate cancer is about 1 in 8, higher if you're from a BAME background, but also there's a lot more funding.
Yeah.
So I think that my point is that male pelvic health is a very tiny area compared to female. And within that area, the research focus is on the older post-prostatectomy men.
Okay.
In terms of where the research is, though, the research would suggest that these men benefit from a more holistic approach, i.e., a bit like that U-point system that you've discussed before.
Yeah.
So that it focuses on, are they getting urinary symptoms? Are they getting pain? Is there a psychological component? Is there, what are the other key aspects? So so the research would suggest a holistic approach is preferable rather than a tissue specific, i.e. focus on the pelvic floor. There's quite a new group which is based in the States that's kind of that's got a big physical therapy component. That's the MAP project. That's the multidisciplinary approach to pelvic pain. So what I would encourage people either listening or reading is to stick into Google the MAP projects. So stick in MAP pelvic pain, and what they're involved in currently, there's kind of different stages that, but what they've looked at is they've looked at trying to profile male pelvic pain. So what do these men complain of? To then subgroup them, which they've done, and also look at markers such as changes in pain sensitivity, immune biomarkers. The other thing that's going on is a lot of subgrouping. It's been like that's happened in low back pain. Years ago, research in low back pain grouped everyone in together, and interventions weren't very successful. Whereas now that tends to be done in subgrouping. So that's kind of what's happening research-wise. If you look, there are smaller studies, but with small numbers, looking at the effectiveness of exercise, which seems to be positive, i.e. getting people more active walking, some internal work, there's some positive results, but these are quite small scale studies. And I think really in terms, what people want in terms of evidence is big meta-analysis. So you look at a couple of randomized controllers, but they aren't there. And it's unlikely that they are going to be there because we're still not entirely clear how these men present, but the MAP project is looking at that.
Right.
And it's also difficult to put together studies that look at, you can't really do a study on, a couple of hundred men. So some of them have ejaculatory symptoms, some of them have bowel, some of them have urinary, some of them have pain, some of them have psychological. So I think what will probably happen, but it's going to take a long time, is maybe the MAP project will lead to more definite subgroupings.
Right.
And that's where the research will focus.
Right.
Which I think is exciting. It's exciting for me because I've met one of the guys involved in the MAP project, and they're very passionate about that. And also, they're it's a well-funded project because you cannot do any research. You can't do any research on your own. You need funding to do that, and unfortunately, there is not as you'll probably maybe agree. Not a lot of people have a lot of interest in male pelvic pain.
No.
At all.
No, that's true. Which I guess that leads on well to the next question, which was when a young man or someone or whoever, a man goes to a GP and asks for help with this, what do you think their suggestion should be in terms of, neurologist, physiotherapist, whatever?
Like, I think, like, it is because these men are presenting with pain in the pelvic region, in addition to urinary symptoms, possibly bowel symptoms, possibly penile erectile symptoms, and abdominal symptoms. It is really important that those men are medically screened initially, because they have to be screened for serious pathology, such as infection, bladder cancer, colorectal cancer, colorectal conditions. So they have to go through that screening process. And I think this is why it's important. So the majority of the men who present to us, or, my other colleagues who do this, the majority of them have been through that process. However, some of them do come through who haven't. So they're the men who've been really savvy online. They've picked up that they've got maybe some bowel pain, some urinary symptoms, and they're thinking, well, I might have pelvic pain. But if they come through my door, I'm not thinking, well, this could be pelvic pain. You can probably pick up, is it pelvic pain? But what we've got is a duty of care to make sure that they're screened for more serious pathology. And I think that's why I think it's important for people to, if they go and see someone, whether that's online, whether that's face-to-face, is that there has to be an assurance that that process will happen.
Right.
Because otherwise you have you could have the situation, which is catastrophic consequences, of someone being treated for maybe pelvic pain, but they've got bladder cancer, they've got prostate cancer, they've got a colorectal problem.
Right.
So I think initially those men present to the GP, and the GP will make that urology appointment.
Yes.
The urologist will see them, or it may be that the urologist will see them and do a lot of tests. They might send them to a colorectal specialist. And I know, and that process is frustrating, because then those men are told, well, actually, there's nothing wrong with the bladder, nothing wrong with the gastrointestinal system, and they're told, and a lot of time they're told, well, actually, the good news is there's nothing wrong. But obviously, there is a lot wrong because they're in a lot of pain. And I would say to those men, it is frustrating, and the message may not have been conveyed very well, but it is important that you've been through that. I think where you get a lot of problems is where these men loop through that again and again. So you get the men who've seen 3 or 4 urologists, or they've seen multiple. But I think that has to be done initially. That's kind of good practice.
So what I was going to mention, do you think there are any misleading avenues that people go down? Well, yeah,
and I think that's a relevant question as well. So I think this is a little bit like female pelvic pain. So I think that if someone decides that they're going to see anyone, I think there's a few things. I think I like to think of it like it's, if one of my friends said, well, who would you recommend seeing for maybe a stomach condition, or a kidney condition, or whatever, I think the basics are, it's important to know what's that person's qualifications. So are they a physiotherapist like myself? Are they a chiropractor? Are they a sports therapist? Are they a urologist? What are their qualifications? And if that's not clear, that's not clear then. It should also be very clear and transparent what that person does. So it's a bit like, I know what the urologists will do, because it's out in the open. I've got a really good friend, Carl Monaghan. He does a lot of work as a sports therapist in pelvic. So I know what Carl does because Carl is quite open about what he does. But if it's not very clear and transparent what someone does, or there isn't that kind of public sharing of information, that's maybe a concern. And I think also because of the nature of these symptoms, which can mimic more serious spinal pathology, it's also, well, who else does that person or people, do they work within a multidisciplinary team? So do they, kind of encourage people to be seen by someone else, or do they hold on to them? I think because of the nature of, these are complex, these are complex patients. They're multi-layered patients. They have a lot going on. I think that if someone is seeing someone online, which, is now very common, especially post the start of COVID, but I think it's saying, well, does that person or person, do they also see patients in clinic, wherever that is, or are they just seeing people, over the internet? I think it's seeing whoever you see, are they a part of a professional organization, which then has professional standards of practice and proficiency? And, we've spoken already, and you've written about this already, about, the kind of complexity of how this condition presents. So you've got people who may all have pelvic pain, but they present very differently. So that needs an individualized approach. Those patients do not respond to the same protocol. You would not do the same with someone who's got loads of ejaculatory symptoms with someone who's got constipation and bowel pain. They're completely different. And also, we see a lot of patients. They're complex. We would never treat everyone the same because it's just not going to work. But also, we would also say, well, I think you should see someone else. I think because of the nature of your condition, you should see someone else. What we wouldn't do, and I think physios are good at this, we would not say that we have ownership of this condition, or we can cure you, or everyone gets better, because that's not how we work. And I think it's like any condition. It's asking those questions, and if those questions come back satisfactory to that person, fine. If they don't, maybe do a bit more research. And I think also, now, like when we buy anything now, and I'm not relating to buying, but we probably look for recommendations, we look for reviews, we do a little bit of research online, and it's good to do that. And I think also, I think especially as a lot of us operate online, is the person you're going to see, whether that's a urologist or a physiotherapist or a chiropractor or someone else, is what's their professional demeanor, behavior, because that tends to reflect how they'll be when they're with you.
So one of the questions that someone asked online was that, let's say that someone who's got this has tried everything, and they've been to run the whole gamut right through from urologists, chiropractors, physiotherapists, but nothing's working for them. Some of them are, I guess I would say, quite desperate. What would you say after that?
Right. And that's a really good question, because some of the work that's been done by the MAP project, and this also reflects what you see in female patients with pelvic pain, in pelvic girdle pain, in chronic low back pain, is it's working out. You've obviously got physically what's going on, but it's also working out in terms of kind of psychologically what's going on. And sometimes it may be that there has been maybe too much of a focus on the purely physical components of it, which are really key, and they are definite and they are important. But it may be that that person hasn't maybe been directed to some of that more focused psychological input. Maybe a subgroup kind of psychosexual therapy. But I think but that's also difficult in that I think one patient comes to mind where him and his partner came, quite a young guy, and he had lots of anxiety, kind of pre-existing health anxiety. And I'm not saying this is pelvic pain is due to anxiety, but this patient had pre-existing health anxiety, and he was going to a clinical psychologist regarding his pelvic pain, his anxiety. And I said to him and his girlfriend, I said, do you discuss your pelvic pain, your erectile symptoms, your anxiety around erections, sexual activity? And he was going, no, I would never do that. They never ask about that. So that seems kind of unusual to me, that someone's having a lot of psychological input, but not discussing those pelvic pain type symptoms. So it's then the challenge of if there is a big psychological component, it's trying to find someone who is qualified to deliver that psychological therapy, but also has an insight into pelvic pain. And that's difficult. It's difficult to find physios who do pelvic pain. It's difficult to find psychologists
who can address both.
Who can address, yeah, exactly. And because I think maybe you and I and the people in the Facebook groups, because male pelvic pain is something we're very familiar with, sometimes I think we assume that everyone knows about it, but that's not the case, like.
Right. So those who have tried everything slightly more physical, there might be an underlying psychological.
I probably didn't explain that perfectly. So it's more so. Sorry?
I know you said it's not the cause, but that there might be a.
Yeah, I think those men who do have a significant additional psychological component, sometimes that may not have been addressed as much as the physical components.
Right. And so I think also sometimes you come across a lot of patients who are on this kind of continuous loop of seeing someone new, having another test, having another injection, having another scan. And sometimes I say to those men, you've been heavily investigated. You've been heavily investigated. Those further investigations are now generating more anxiety. Yeah.
You get the high of seeing someone new, but then you get the low when they say, well, actually, I can't find anything new.
Yeah.
And sometimes I would say to those men, it's time to step off that for a while, because even that can start to reduce some of that stress, anxiety, that kind of mood, almost volatility.
And so let's say, what do you think that more can be done to raise awareness of this?
Yeah, and I think what is important is to, the blogging is good. I think in my perspective, what we've tried to do is to get male pelvic health a bit more prominent at some of the physiotherapy conferences. I think it's I think the Facebook groups do really important work, because they give a home to some of those men who gives them some direction. I think it is what we try and do, and we're only a tiny clinic in Birmingham. What we tend to do is trying to do some work with the GPs, with the urologists, but rather than on a one-to-one basis, what we will try and do is to see, well, can we orchestrate to present to at one of the urology conferences, at one of the GP networking events. What I think what's been quite positive is we've, a bit like you're doing really, we've got a lot of our patients, a lot of our male patients, to write about their condition.
Right.
So someone's been as a patient, we say to them, would you write something to us, and then we'll anonymize it, and then we will put that in our blog, and then Google picks that up, and we do a lot on social media. Used to be on Twitter, now probably more Facebook, Instagram, and I think the more people do that, the better. I think things are changing very, very slowly, because I think what I see now, which we used to see, was you get patients coming sooner, or you get patients going to the GP sooner. That's because they'll find stuff on Google, or so I think things are changing, but it's still, I think these men just get a really raw deal, like.
So what time frame should a sufferer seek a physiotherapist then after the symptoms? That was one of the questions.
Yeah, I think that depends. And I think COVID is not going to help that, because really the route that this should take is GP, urology.
Right.
That's got to be done, really. And then some of those men, if they're getting lots of bowel symptoms, they'll need to see a colorectal specialist.
Right. So
those things need to be checked. That's really important, that they're not masking something like bladder cancer, like testicular cancer.
Even
in the younger, and yeah, but even those men that are older, or the men who come with erectile dysfunction, say, maybe my age or a bit older, they may have heart disease.
Right.
So they should go through that process. So I think once they're through that process, that takes a lot of time.
Yeah.
Especially here in the UK, we have an amazing health service, but things are slowed down because of COVID.
Mm-hmm.
So I think we don't tend to see, on average, probably those men are maybe 9 months, couple of years into symptoms.
Right.
I think we see some of the younger ones sooner, but they're tending probably not to present with pelvic pain. They're presenting with kind of like a hard, flaccid type presentation. So they've had maybe a bit of penile trauma during sex. They've maybe something else has happened to the penis, bit of trauma. So we see those early, but it may be that they're a bit younger. They spend a lot of time online. They find some of the forums. But it's not a case that we're seeing people within a couple of weeks of symptoms. It's well down the line.
Right. Okay.
But that is changing. Like, whereas in the past, I know when I worked in Roots Clinic in Southampton, we would be seeing people down there who'd maybe had symptoms 5, 6, 7 years.
Right. Yeah.
And also, really, in the UK and in other countries, physiotherapy for male pelvic pain, it's not a massive area, because not a lot of people are doing it.
No.
So if you lived in, someone would say to me, well, can you recommend someone in Liverpool or Manchester? So I know a lot of physios, but you'd kind of struggle to find someone. Same with female pelvic pain. So the provision isn't there. So that's why it's difficult for people to maybe find someone to see them.
Right. And so just these two last questions. Again, these are from people online. How long would your treatment last, and when should a person stop if the symptoms are not improving?
Yeah, so I think the second one is the really important one. So I think because most of us, i.e. physios, have worked in the health service, we're quite used to auditing and reviewing how things are going with patients. So I think what we would always do is, in that initial session, is work out what are called some subjective markers. So I would work out maybe with you, or another is, you know, how do we know, or how will you know if things are improving? So that might be the ejaculatory pain. It might be the urinary frequency. So currently the patient's going to the loo every 20 minutes.
Yeah.
It might be that they're getting a surge in pain after bowel movements that's lasting maybe 6-7 hours. They're not sleeping. Their walking is down to 10 minutes. So you try and pin down some of those subjective markers with the patient. So you really, we pin those down. So then we can say when they come in, things aren't going to change in a couple of weeks, but further down the line, we would say, okay, well, you know, when we had the first couple of appointments, these are the things we discussed. So you pin down, are those things changing? If those things are not changing, things aren't changing. What we also do then is look at some of the objective marks, the things we can measure. So that may be things like what's happening in terms of the excursion of that pelvic floor on ultrasound. It may be the response to palpations, that's that allodynia, that hypersensitivity. It may be their pelvic floor function on ultrasound. It may be the response to internal palpation. It may be their spinal hip range of movement. It may be what. So we have tight subjective markers. You know, that's things we ask the patient, things that we measure. That way you can kind of keep a kind of a good eye on what's happening overall. Because it's a condition that fluctuates. So you could see someone on a good day and things are great, but that's probably not a reflection of what's happening in the condition.
No.
You could see someone on a bad day, but that may also not be a reflection either. So it's an overall, it's an average picture we look at.
Right.
And if those markers are not improving, something else needs to be done.
Right.
I think what we have, I suppose, is a little bit of an advantage in that there are more than one, i.e. it's not just me there. So if I feel, well, I need a fresh pair of eyes here, I'll get my colleague Lisa to see them, and she's very experienced. Or I will get another of my colleagues who might be, whether my friend Adrian is based in Reading, and that seems a long way from Birmingham, but it's all relative really. And then it's trying to work out, well, if things aren't improving, why is that?
Right. So you're just constantly customizing.
Yeah. And I think also, I suppose I'm in the, you know, relatively fortunate position of, you know, I don't just do male pelvic pain. You know, so I teach 2 days in the university in Coventry. We see a lot of female pelvic health. We see a lot of post-prostatectomy patients. So I think I do male pelvic health or male pelvic pain because I'm really passionate about it. And I try and encourage other people to get involved in it, other physios. So, you know, and it's a bit like Ruth was. So Ruth was passionate about it. And so we kind of do it because we are passionate about it. And it's very rewarding work, rather than needing to hold these men for as long as possible. No. So that, and I think physios are quite, okay, there's the odd exception, but physios are generally like that. if we wanted just full clinics all the time, we'd be treating back pain or sports injuries, because there's tons of those people out there. Running a pelvic pain clinic is, no one really knows you do male pelvic pain. Physiotherapy isn't a big thing for it in terms of marketing. So, there are easy ways. There are much easier ways to fill a clinic. In terms of this, the other question as to how often we see patients, not that often. I think people would be surprised at that. So, we would see someone, if they're traveling a bit, we would probably see them for 2 hours, because that gives a lot of time for all the questioning, bit of a break, the assessment, the explanation, start to do some treatment, send the patient away. I don't think you can do that in an hour. An hour is quite rushed. It's quite an intensive hour. 2 hours gives a bit more time. And then we would follow them up probably in about 3 weeks' time or so.
Right.
Because I think what I wanted to ensure is that they're going to spend a little bit of time with me. They're going to spend most of the time on their own. So we need them kind of really being clear what they are going to do. So we would see people maybe 3 weeks, 4 weeks down the line, see them, reassess them, progress things, change things, and then maybe follow them on after that. But you do, this is a slow changing condition, but these patients, things do improve. A lot of men do really well. Yes. But we would see some of those patients for maybe 6-9 months. But what happens is the frequency really drops down. So you mightn't see someone for maybe 2-3 months.
Okay. So it's quite accumulative. The more they put into it,
but what we definitely do not do is, we're not seeing people 3 times a week or every week for 10 weeks. So we just don't do that. And I think that can be a tricky conversation, because a lot of these men are in desperate situation.
Yeah.
And they will say, I want to see you every week for the next 10 weeks. And we'll say, well, actually, that's not really what we do. And they'll say, but I don't mind coming. And we'll say, well, that's not really what we find works. If you over-treat someone, especially if they've got a lot of hypersensitivity, lots of pain, you make things worse.
So the final question is, again, someone from online has requested this. What's your opinion on Botox or surgery as a way?
So Botox. So here in the UK, Botox is used. I think more so probably for female pelvic pain.
Right.
When you look at the research, it's probably more heavily focused to vaginismus, vulvodynia, so female pelvic pain. But I think that probably reflects that there's just more of an emphasis on female pelvic pain than male pelvic pain. In terms of male pelvic pain, sometimes patients will have that, particularly if they've got a lot of more superficial spasm around that external anal sphincter.
Right.
There's also a point that it's easier to access than going into that deeper pelvic floor. I think when you start to look at surgery for pelvic pain, this is probably reflective of the what happens for low back pain. So here in the UK, a lot of our medicine is delivered by the NHS, so that tends to focus on what's cost effective, what's evidence. So there is not a lot of surgery here for chronic low back pain. Where you have a private medical system, there tends to be a lot more surgery. So when you look at the American literature, heavily surgical driven for low back pain. And I think that's reflective of pelvic pain also. You don't tend to see many patients who have surgery here in the UK. Maybe more so in the States, possibly if you look at that literature. And I think that's probably a good thing, because this is not a specific tissue problem. So say those men who've got pudendal nerve involvement, so they're getting some involvement in that, they're getting pins and needles, numbness, quite nasty nerve type pain. So, but they're probably also getting loads of other things. So I think surgery is not something we see a huge amount in the UK. We see some, but it's not a massive thing. If you look at some of the literature from areas where you've got purely private system, you're probably going to find more. So, if people are listening to this or reading this in the States, it's probably very different over there.
So they would use surgery for male pelvic pain?
They do, yeah. They sometimes people will have surgery around the pudendal nerve, but the literature on that's not very positive either.
Right.
So it's not something that you tend to come across a lot in the UK or Ireland. No. And that's also in, there's female pelvic pain is a bigger area, but the symptoms there's a lot of similarity. So you don't, here in the UK, you don't also see a lot of women with pelvic pain going for surgery. It's just not a thing here.
What do you think of it being called interstitial cystitis?
Yeah, so that's a term that's probably evolved now into bladder pain syndrome.
Right.
So that really involves the men whose symptoms are who've got pelvic pain,
right,
and a lot of kind of lower urinary tract symptoms. So they're the men who get a lot of maybe lower abdominal pain at the front of the pelvic region when their bladder is full. They're maybe getting symptoms on urination. They're getting maybe frequency. So they're going a lot. They may be getting some hesitancy. Right. So it's difficult to initiate. They may be getting some urgency. They may be getting kind of pain on urination. So the men whose symptoms are very heavily bladder focused would probably fall under bladder pain syndrome. The kind of more common terminology, but this won't really trickle, I think, into patient language, is the kind of new term for overarching term is urological chronic pelvic pain syndrome. So that's taking in those men with bladder pain syndrome, those men with chronic pelvic pain.
Okay, and so that was what we were going back to at the very start as to what the sort of overarching umbrella term for it. Yeah.
So I think it's pretty accepted that men with bladder pain syndrome will probably be told, which is correct, that they've got chronic pelvic pain syndrome. But they may also be told they've got prostatitis.
Right.
And in a way, it's correct because it's type 3 prostatitis, but in a way, it just adds to the whole confusion, stress, anxiety, because they're thinking, well, I've got bladder symptoms, is there something wrong with my prostate? But there probably isn't.
Right. Well, I think it's fantastic. We've covered a lot there, and it's been incredibly useful. It's such a interesting but unexplored topic, or publicly unexplored topic, I guess. So let's wrap that up, and thanks a lot for your time, Gerard.
No, and thank you. And I would like to just say thanks to you for taking your time. And I would also like to thank all the people in the groups who went to the trouble of submitting a question. Hopefully we've answered those, and hopefully people will see that their question has actually been used.
Yes, no, that's great. Thanks a lot, and I'll get this up and see what the responses are.
And we also both got the memo on the white shirt.
Yeah. Thanks a lot, Gerard, for that.
No, not at all. No, and I hope it was help, and look forward to seeing how it ends up.
Yeah, great. Thanks a lot.
Okay, nice to speak to you. Enjoy the rest of your day. Bye-bye. Bye.
Bye-bye.